Everybody, welcome to the live billing drop-in. Yay! It's so funny that there's 3, 6, 9, 12, about 15 people here, and then we have how many online right now? 36, maybe more. Yep, 36. Sweet. So welcome to the live billing drop-in here at the UC. We're going to kick things off. We're super excited to have you all here. And folks at home, don't worry, we will be keeping an eye on the chat so that we can get all of those questions as well. But yeah, we've got, as per usual, we got a pretty regular agenda for you guys. For those of you who haven't been here, online or in-house, this is the premise. Basically, this whole thing is your time. Start to finish, it's really about you guys and your questions and your thoughts and your discussions. We have a panel of about half of, I think more than half of our entire team is here, including Tim. Tim, come on, we have a seat for you up here. Oh, well, yeah, okay, that's fair. Tim's going to scan codes for a little bit. Tim's our newest member. And we'll introduce everybody in a second, and we'll go over all of that. But basically, in short, if you have a question at any point in time, raise your hand or shout out in the chat, and I will get to you. I'm going to be running around with the mic today, and we want everybody online to hear your questions. So if you do have a question, wait until I get over with the mic so that you don't have to repeat yourself. So, our crew, this is our entire crew. I'm going to highlight the folks that are here right now because those are the most timely that you know who they are. So we have Ben on the end of the line here, and Ben is one of our SMEs and consultants. We have Michael, who is our product designer. We have Jan, who is our HR ops person, but she also knows a couple things about coding, I'd say. Kristen is our BA, and well, she's not actually. Oh my God, that changed a long time ago. Kristen is not our BA. Kristen is our project manager. Kristen used to be a BA. Now she's a project manager. We have Jay, who is one of our developers. We have Tim, who is our newest team member, and he is also a developer. Oh, he is on there. Okay, good. He was at the tail end. We have Brian Kennedy, who a lot of people have worked with. He's one of our certified coders, and he is also an application specialist. And then we have Kelsey, who is our BA. And then we have me. I am a quality assurance analyst, and I'm going to be moderating today's session. So, just really quickly before we get started, our vision. Our vision is to get every pediatrician paid the maximum amount for every service rendered with the smallest amount of administrative effort. We basically are attempting to make it as easy as possible for you guys to get paid and your docs to get paid for the work that they do. We know that it's a tough fight. PCC can't fix insurance companies, but we can help give you guys the tools that you need to fight those fights. So here is like a rough estimate on our discussion topics. We got 3 main ones. We have just information on the Change Healthcare update. For the most part, it's the same, but we'll go over that when we get to it. We have a coding chat about the new ICD-10 code updates. And then at the end, if we have time, we're going to do a little bit of a development show and tell for you guys what's coming up, and we're going to get feedback for you guys. So, without further ado, I am going to open the floor to questions. And in person, I know it can always be a little bit more awkward because people are hesitant to ask questions. But for real, if there's anything that you have learned this week or has been on your mind lately or has come up while you've been away from your practice, you can ask in the chat or you can raise your hand and I'll come over to you. And if you don't have a question, then I'm just going to stand here and talk. And not fun talking. Yeah. It's like the parents, well, we're just going to sit here. No, but for real, we'll give it a second if anybody can think of questions or if anybody wants to chime in on the chat. And then if not, we can dive into a couple of our stuff. But going 3 times? Going 4? Yeah.
Raise your hand if you've never been to a billing drop-in. Well, not you, Tim.
So we have 3 of you. Wow, actually,
Okay.
welcome. And if there's anybody in the chat that has never been to a billing drop-in, let us know too. Yeah, it's fun. Also, I didn't even mention that one of the reasons why we do this is because you guys are subject matter experts. Whether you think so or not, you guys are the ones that are out there dealing with all of this all the time, every day. And half the time, you can answer each other's questions just as well as we can, if not sometimes better. So we definitely try to get everybody's voices in the room together. Hello from Georgia. Hi, everybody. Oh my God, cute. Sorry, I love this. But all right, well then, we may as well get started and just give a quick update on the Change Healthcare stuff, yeah?
So the Change Healthcare is going to be myself this time. So normally if we're doing a billing drop-in, and those of you who have been know that it's everybody. Everybody's on board. We get our entire team in the billing drop-in, and that's awesome. But Justin, who is our EDI expert extraordinaire, who would normally talk through this, is not here. So I'm going to go ahead and talk this a little bit. So the first thing is the Change Healthcare update. Who's still being affected by that? A few of you, maybe? A little bit? Okay. We tried our best to we tried our best to keep you guys up to date as we were doing things. So this Change Healthcare, at the start of our drop-in is normal for us for the past several months, because we want to make sure that you all understand we know that things are still happening. We are still diligently working behind the scenes. I don't think this is on the slide right now, but I know we have our EDI experts in Vermont right now working to make direct connections with some entities, just so that we don't have to hit Change Healthcare, just so we can direct it and have as many direct connections as we are able to. So we are still working behind the scenes. As this first slide says, fewer than 7% of total eligibility requests processed by PCC are routed through Change Healthcare. So that were the affected gateways. We had a bit going through there, but we are trying our best to make sure that we work on eligibility and get that up and running for everyone as soon as we can. It does say that eligibility payers still affected include Aetna Better Health and Molina Healthcare. Justin did say, yeah, I can see Brenna in the front going, yeah, I know. These slides are just about the same as last time, because the status from last time is still what's happening today. So we are still cleaning up things. There's still a few things that are outstanding. For electronic claims, roughly 2% of total claims are routed through Change Healthcare now. So we've been able to redirect and point other directions. Some of you are still going to be affected. 2% doesn't sound that much, but some of you are still being affected by this and still seeing that. Represents miscellaneous Medicaid, of course, and some commercial payers. And last but not least, ERAs. Actually, I think I have one slide after this. For the ERAs, Change Healthcare continues to restore payer connectivity. Are you all seeing your ERAs come in a little bit more these days? Anyone really affected? Does anyone have situations where you're not getting ERAs from one payer specifically, or are we looking pretty good? Pretty good? Okay, that's good to hear. So Change Healthcare's payer enrollment services for ERA and EFT remain inaccessible. So, for us to be able to move some of the stuff, we'd have to re-enroll, and that's, honestly a little difficult right now because we have to depend on these third parties. And last but not least, protected health information breach notification. So I'm going to talk to this a little bit. I'm going to lean on Jan because she knows about this as well, but there is a breach notification that will go out to the affected people. This isn't something you'll have to take care of as far as I'm aware. And I'm having a hard time actually reading the slide because the red on the gray. But Change Healthcare will mail notification letters to affected individuals starting July 20th. So that is the newest thing in here because it was a breach of PHI. And it wasn't your breach. It was Change Healthcare's breach. So they'll go ahead and send out letters to affected people starting July 20th. So you might start getting phone calls from people that they've received these letters. So heads up on that one.
There's a comment on the chat, Kristen, regarding this. It says that I have to get all my Horizon EOBs from Availity. That's Susie. I don't know where you're from, Susie.
Susie Silver, okay. And I'll let you say what Mary just answered.
Oh, okay. Mary says that we're working on it from several angles. We feel your pain, and we really do.
Thank you, Mary. One thing that's fun about the drop-in is we get answers from everybody. That's Mary Lockwood, one of our EDI specialists, right there on it. Any questions about Change Healthcare? You guys all set? No burning questions? You are the quietest crowd we've ever had. That's not true. We've had other quiet crowds.
We also, it's also a Friday afternoon. We get it.
It's
We get
Friday.
It. It's been a long conference. Well, it was. Wow.
Yeah.
We
We did have a
good
bigger crowd. Oh,
Yeah.
really? Oh, right.
I think
Yeah.
that's why they put us in the big room.
Yeah, that's true.
Yeah.
All right, I'm going to give this up then if no one has questions. If you do end up with questions, just raise your hand. Those in the chat, please go ahead and pipe up.
Sorry, there is something in the chat, if that's okay. It says, with the insurance eligibility feature, what is the best practice for us to add new insurances to our TED table? Should we ask PCC before sending claims or just load them and send them?
A little bit, it never hurts. Okay, we'll try to minimize that. It never hurts to, I guess I'm just very loud. May I borrow the other microphone, please? Okay, we'll give this a shot. It never hurts to contact us and see if you have a new insurance in your table. It's always good for us to make sure that things are looking right, especially on the EDI side of things. So especially, please, if you have something new, it never hurts to just reach out to us and ask us to do a once-over to make sure things are right. If you can add that in the table, that's great. We may make some minor tweaks, but especially for new payer IDs, that's especially important for us to see to make sure things are routing the way they need to.
And Mary did comment, Susie, we've been attempting to build our own direct connection with Horizon to a little sluggish response from them. Great. We love that. Sweet. Anything else in the chat, or are we good right now? Sweet. Any questions in the room? I can keep going more high-pitched if I need to. It's a quiet group. That's okay. Well, Jan?
Long as there's a lull, I wanted just to touch on to ask if anybody had seen any unusual interruptions in things like eligibility or exchange with payers today. It's not uncommon for there to be, a handful of eligibility requests that come back with no answer or come back with the payers unreachable. They usually self-resolve within an hour or sooner, but the headlines that you saw this morning that are canceling people's flights and affecting the ability of hospitals to care for people in the UK, that same breach, remind me the name of the... CrowdStrike, thank you. The CrowdStrike, not breach, there was a patch. They patched, a software patch of theirs went out bad and prevented a lot of security measures from waking up this morning. And Justin was able to give me up-to-the-minute information about whether that's been affecting PCC systems. He's been talking with other folks back in Vermont, and the daily outages that are typical, the payer goes offline or the payer doesn't wake up as early as PCC does or as early as you're looking for eligibility, making eligibility requests. If any of the real-time data exchange is abnormal, please do let us know, because as things are looking to us in Vermont, it's looking like things are coming back up on their own and it's business as usual. So please do let us know if there's anything out of the ordinary that you guys are experiencing today. Availity in particular, there were some statistics Justin shared. They observed a 32% decrease in inbound business-to-business transaction and a 24% decrease in inbound API transactions, which is it's Friday. I don't remember what API stands for.
Application program or interface, but that's not helpful.
Jay said a thing that's not helpful, so I won't repeat it. It was not disrespectful. It was just unhelpful. I should just repeat it. So volume decreases are due to the CrowdStrike issue today, but nothing else out of the ordinary is happening. So please do keep us posted if you discover anything that seems like it's mounting or worse than usual. And he goes on to say that even those percentages are not necessarily eligibility related. So I don't even know what to tell you to look for, but it seems like each week we wake up to something new, somebody not being able to do business as they expected when we all got up on Monday morning. So it's rolling with the punches, and we're doing our best to keep the latest information out there and to adapt as we come across this stuff. So please do keep us posted on what you've got going on.
Thank you, Jan. There has been some chatter in the chat here, and I'll start with Mary. She said that there may be some movement with Change Health migrating some of the 835 enrollments, but this is not confirmed. And Jack asked, how does the payer list get updated? Is it an autofill or manual? And Justin replied, yes. On Wednesday, we PCC finally received an acknowledgement from Horizon that our direct EDI interface development has been submitted to security for approval. This process normally takes 2 to 3 days for approval, so we should see progress shortly. And also Phil says that API stands for Application Programming Interface.
He said that wasn't helpful.
Teresa asked, we have 3 lactation nurses that work with our moms. Are we better off billing under our mom's ID number or bill it at a higher EM code?
Okay. Yeah, so if I understand the question, lactation billing can be billed in either of those ways. If you don't mind investing in the overhead, the demographic overhead of treating the mom, many payers will acknowledge pediatricians as lactation specialists, especially if they're licensed lactation consultants. And billing under the mom can be more direct. It's less, you get less back and forth, less question from the payers about the nature of the service. But the other option, the option of increasing the complexity of the E&M isn't necessarily the most specific, most accurate way to report those services. There are a handful of approaches that you can take, and the best resource I can recommend is from the AAP. There's a 2-page lactation billing exploration, and it's 2 pages long for exactly the reason that there are several approaches that you can take. It depends on the licensure level of the people working with your moms. It depends on the type of service that's being rendered, whether it is counseling or direct support. So without having those at the tips of my fingers, I will happily find that PDF and share it in the chat and include it in the materials that we collate for this event and have those online as well.
We have an in-house question. Yeah, for sure. Hold on.
We just started lactation, and we are billing actually for both the mom and the baby. Is that compliant to do that? I just want to.
So the question that I heard is that you just started doing lactation and you're billing for both mom and baby.
Yeah.
If you're not duplicating the reporting, if you're only reporting each service for either mom or the baby, that snack pack combination probably is not, as long as it's not duplicative. If you're reporting each service only once and you're using accurate coding,
Okay.
I don't see any harm in that.
Okay, perfect. And then we also found for our HMO plans for moms, we're just having them do self-pay because we can't get the referrals. We're finding that all those claims are being rejected if they have an HMO.
Oh, okay. Yeah, so, yeah, if you've got moms that are self-pay, So for HMOs, yeah, so they're going out of network. They're opting to go out of network. Yeah, getting those referrals. Getting the obstetricians to give those referrals within those first few weeks after birth is that can be a challenge. Yeah, so if the moms are willing to do self-pay, if you don't have because you don't have a contract and you don't have a direct relationship with mom as a patient in your panel, I'm not immediately thinking of any reason not to continue that. Yeah. If you were an OB contracted, but even at that, if the patient's choosing to go out of network, whether you are an OB or not, they're just receiving services for which they should not expect payment. Yeah. I'll speak up if I think that through any differently.
Thank you. Oh, sorry. Kelsey, anything else in the chat?
Yeah, so I actually wanted to apologize because I did ask Jack Sobrin is in the chat, and he asked the question, how does the payer list get updated? Is it an autofill or manual? And I thought we had answered that, but we had not. But I was actually hoping, Jack, could you at some point please clarify or expand on what you mean by payer list? Because we've been talking about a couple different topics here. I just want to make sure we get your question asked, or answered, sorry.
Any other in-room questions? No? Let's see if Jack responds on the chat for a second. And if he doesn't, then we can keep moving. Brian, do you want to take over for ICD?
Hello, everyone. So the next thing we're going to go into is our coding chat. The first information that we want to talk about today is CDC has noted that we have an increased risk of dengue virus infections in the United States. So it's something to keep track of with your practice. There is an AAP article that goes into some of the clinical readiness that they recommend for that. Specifically just numbers in general. In the United States, as of writing this article, there are a little over 2,000 cases that have been reported and about 1,500 in Puerto Rico. So there's, that declared a public health emergency in March related to dengue. So just as a note with keeping in touch with your providers and letting them know to be mindful that if you're in an area that might be higher risk at that, then keeping in mind the symptoms of dengue and looking at what you might need to do for coding for that. You can look up the data, ICD-10 data. I realize that I probably should have put a slide in here to have the links for those specifically. We can work on sending that out to you later as well. But just looking at the information for making sure that's readily available, so if the providers are suspecting that is something, then you have that maybe saved as a favorite in your practice, so it's more readily available for them to select. Do we have any questions on the matter?
Any questions on dengue? Or in the chat, Kelsey? No?
There is no question regarding this in the chat, but I did want to put out here that Justin, one of our EDI folks, just wanted to let people know that regarding the separate Microsoft Azure cloud and CrowdStrike outages, PCC's own EDI systems are unaffected, and we are seeing EDI transactions like eligibility requests and responses processed as expected for many, if not most payers. But if we have heard from some payers that their systems are, from some payers that their systems are affected. So just letting you guys know.
Great, thank you. All right, Brian, you're good to go with the 2025 updates.
Right. So we're going to go into some of the 2025 ICD-10 updates. Those are going to be effective October 1st. So you'll see those will be pushed over to your system. I believe we pushed those prior, and then they're just activated the first? Okay, so Jay is shaking his head yes. So those will be in before October, but again, we'll have dates set so that those are not going to be usable until October 1st for your claims. If you do try to attach that ahead of time, it will probably give you an error message saying it's not valid for that data service. So do keep in mind for those that if you do end up using some of those, that's there. In general, we kind of just do a summary of items that we felt are more relevant to pediatrics. This does not encompass every one of the ICD-10 changes that are there. We do have links here that are they're big files that are coming out for all of the addenda and all the guidelines that are available. Those are free manuals that you can get. They're rather large, but those are freely available in PDF format. So again, for your own practice, it doesn't hurt to at least look over the tabular addenda once a year and make sure that you're aware of what those changes are. But I think it's smaller than last year. Jana noted that we're about 45 pages this year versus the 61 pages that were last year. So not as many changes as last year, but there are some notable ones that we wanted to go and review. So the first one we're going to look at is the endocrine, chapter 4, so endocrine, nutritional, and metabolic diseases. There have been some additionals items for this. We have some new codes here surrounding obesity. So we have overweight and obesity. It does have some verbiage there to revise to code these ones, just adding in more information for the new codes that are being added. But we have new classes here that are listed here under the E66.8. So we have E66.81 and having that go down through class 3. The definition for these ones is that the obesity levels for these specifically are listed. If you look at that addenda, you'll see where those ranges are. So you've got greater than 120%, under 140% for those. So you'll see information on where those ranges go, and they have them broken out for class. Next we want to go over is chapter 5. So we have mental, behavioral, and neurodevelopmental. This is going to be a common theme, is there are some eating disorder related items that are going out and having some more specificity that is being added and new categorizations for those. So we're keeping that anorexia nervosa restricting type, and then the new codes below it add the specificity for mild through extreme, and then there's in remission and unspecified. For the mild through extreme categories, those are based off of patient BMI. So if you have it where the patient BMI is 17 or higher, that brings it down to mild, and then you have between 16 and 17, 15 and 16, and then less than 15, respectively, for each of those. A note for use for in remission, they did have a caveat with that, with it is expected to, if the patient is fully in remission or partially in remission, that can still be qualified with that ICD-10 code, so they don't have to be fully past that for it to be used. And then we have the unspecified code at the bottom of that. And you'll see if you go to the next slide as well, that's going to, again, same idea with your different eating disorder codes we're going through with the same, this is the binge eating / purging type. Again, you have that mild through extreme categories that you have for those codes. Those BMIs between, I believe for most of these, I'll make note if it's different, all of those do focus on those exact same BMI ranges for mild through extreme. So it is, again, that 17 plus for mild, going to the less than 15 for the extreme. So those are going to be your ranges that you're looking for those particular codes. Going into bulimia nervosa, again, new codes, pretty similar to what we're looking for the anorexia. We have mild through extreme, and then we have in remission and specified. These ones are going to be based off of the compensatory behavior episodes each week. So your mild is going to be 1 through 3, your moderate is going to be 4 through 7, severe is 8 to 13, and then extreme is 14 and plus. In remission, again, is full or partial remission, but that's what you have for the bulimia nervosa. We continue on to binge eating disorder. Again, same idea as what you had with the previous set. These are going to be based on the number of binge eating episodes each week, with those mild through extreme categories with the same number of those, so 1 to 3, 4 to 7, 8 to 13, and then 14 plus respectively. Next chapter we have is chapter 6, so diseases of the nervous system. There is a new code that is categorized under and unspecified encephalopathy, if I can say that correctly. Nailed it? Okay, good. New code, it goes into, again, off of that G93.4, we have G93.45. So we have developmental and epileptic encephalopathy with a note, as well as early infantile version of that as well. So that is just something to keep in mind. We also have a new code for serotonin syndrome, also being classified with serotonin toxicity. A big note for this one, especially with SSRIs, it does have a code first descriptor for that as well. So it wants you to code first the poisoning due to the drug or toxin specifically. So if you happen to know what the medication was or know what the particular poison or toxin was that falls into this for the serotonin syndrome, that should be coded first during your billing for those going out the door. Next section we have disease of the respiratory system. Again, this does break out for disorders of nose and nasal sinuses, just adding more, like a lot of specificity for this. Before, I believe it was just that J34.8, but you can see going out that we have a lot of different specificity with those. I won't go through all of those, but you can see it does go out quite far. I think the longest is that like J34.8200. So rather specific for those, but keep in mind that you will see a much higher level of specificity for that in your EHR. Next one we're looking at is Chapter 11 for disease of the digestive system, looking at Crohn's disease. Again, new codes for these. Again, this is a use additional code to identify any associated fistulas if applicable, and going through each of those with anal, anorectal, and rectal, as well as some for ulcerative colitis, adding those on there. So again, if you have patients with Crohn's or ulcerative colitis, then there is some more additional codes that you can bill alongside the K50 and the K51 for those. So you have those additional codes to identify any fistulas that are present with the patient. More of these just continued on, different varieties of the anal fistula, and again, different specificities for those. And continuing, and continuing. So we do have rather large amount of those for your review. And again, please reference the slides for those and also the addendum. So yes, we are here. Disease of the musculoskeletal system and connective tissue. We do have a bunch of new codes that go along with the M65.9, more specificity for that. So it goes much more detail with the specific site for that goes beyond the unspecified. You're looking at your shoulder, forehand, arm, etc. So you have those as well. A note for the codes you'll see on the screen, we have, like for example, the M65.91. There is a hyphen after that. That was just to help this be a little bit more readable and not have as many codes on the screen. The ones with the hyphens, all that extra character that would be in that hyphen space, you do have one, it includes for your laterality. So you have your 1 for your right, 2 for your left, and then 9 for unspecified. So for each of those codes where you do see that hyphen, that does have that spot listed or available for your laterality to be added in. Chapter 15, something that is always added, I believe Jan added this in for her talks, is codes from this chapter are never reported for the baby. Would you like to go into more detail, Jan, or is that enough? Yeah.
Yeah, I know in conversation with one of you earlier today, I mentioned anything that starts with the letter O, it can be really, really tempting to, in that immediate post-birth, the perinatal period, there are some codes that are just more specific in the mom's experience, and the mom's experience has a bearing on the baby's condition. It can be really tempting to use those, and they will always be denied. There would not be a payer that could hold their head up if they let their edits get away with paying a tiny little baby's claims for codes that are appropriate to a woman of childbearing age.
Thank you. All right, Chapter 17, Congenital Malformations, Deformations, and Chromosomal Abnormalities. We have new codes for specificity with the Q23.8 as well as the Q78.8. So going to more of the bicuspid aortic valve, congenital mitral valve cleft leaflet, and then for the Q78.8, Kleefstra syndrome. Chapter 18, these codes are not changing. They are revising some of the language. Before it was an excludes that it was stating vomiting associated with bulimia nervosa. You'll see it's same verbiage for that with the exception of you'll see a hyphen at the end of that F50.2. Again, all that's doing is stating that we have new codes for those and having that additional hyphen on the exclude statement just allows it to be more specific. It says, yes, it's not just for the main code, it also includes all the higher specificity codes below that as well. And we do have a question from the chat.
We do. Wendy says that insurance companies will not pay for any diagnosis codes that say unspecified. So why are there new codes that say unspecified?
Say clinically, if that ends up being something that the provider feels is the best clinical and proper code for it, then following proper coding guidelines, then it should be used. Whether the insurance carrier will pay for it or not is unfortunately distinct from that. If you're following proper guidelines and if you feel that that unspecified needs to be there, then it should be there. You don't want to be putting, especially for laterality, putting a 1 or a 2 on there if you can't determine that or it's not known. Putting unspecified is what the correct code would be. But again, with what the proper guidelines are versus how it's being paid is, I feel like, a fight that we have constantly. And seemingly it's not an unusual thing in general. Expand.
Yeah, there are some that are easier than others. Brian mentioned the obvious example of laterality. You're always going to know that in a primary care setting. It's much more useful in places like trauma care where a clinician knows of a condition that someone came in with, but maybe they are not conscious and not able to confirm the either or of a condition that has a bearing on the way that the trauma care is being delivered, but you can't see it. You're not visualizing it. You're sending the claim in before you can make a determination, and it may not be germane to the service that's being rendered and reported. A less obvious one is places where you would render care for things like certain infections. You might, I was just talking with someone in the billing, I keep wanting to say the billing drop-in, and it was the billing walk-in earlier today. These names need to vary a little bit more. In the billing walk-in earlier today, someone asking about a similar question: why are there unspecified? How do I get my payers to pay for unspecified? And the answer in this case ended up being exactly as Brian said. You have to appeal some of these, because if you're trying to bill something like a conjunctivitis and you bill unspecified, what that says is not that you don't know that they had conjunctivitis. You don't know what organism their eye was infected by. And in primary care, you're not going to go to the bother of culturing a conjunctivitis in order to treat it. You're going to treat it, and it's not going to matter as much to you matter as much in your treatment choices what the organism is. So you don't have any cause to gather that information, and you're not going to put the patient through unnecessary testing just to pick a code. So unspecified is completely clinically appropriate in that case, and unfortunately appeal is generally the method that we have to take to educate the payers to that effect.
All right. Next slide, we're looking at a new exclusion for abnormal glucose. Currently, this now will add the type 1 diabetes, the E10.A series. So that is a new exclusion that goes along with that. We also have T45.1 is not new for Chapter 19. It does have a new exclusion listed there So again, because of the T45.A series, which is the new code that is being added, poisoning by adverse effect and underdosing of immune checkpoint inhibitors and immunostimulant drugs. That is a new code that has then, the exclusion is added for T45.1. As a note, that T45.A also excludes T45.1, so this is definitely a situation where it's one or the other. You can't use both. Continuing on, these are the expansion codes of the T45.A. I won't go through all of these, but you can see the different levels for those and the reasoning behind it for the poisoning, whether it was intentional self-harm, assault, accidental. So each of those go into more detail and more specificity. We do have a new use additional code for the T63.4, so if applicable, use for anaphylactic shock, T78.2, so we do have that added on there along with the toxic effect of venom. Continuing on, we have Chapter 21. We have factors influencing health status contact with health services. So this is looking at the new codes, which have Z15.1, Z15.2 on this slide, looking at genetic susceptibility. It also does include a rather large list of code alsos, if applicable. It will list related disorders here. So if you are ending up using that Z15.1 or Z15.2, note what the code alsos are for those. Continuing on, we'll start looking at the social determinants of health, and we have persons with potential health hazards related to socioeconomic and psychosocial circumstances. There has been new codes being added into this. I think these are probably going to be rather prevalent in your practices. So we have a Z59.71, so we have insufficient health insurance coverage. That also specifies more information on what that could qualify as below. So it's inadequate social insurance, insufficient social insurance, or no health insurance coverage at all. So that's where it would qualify for that Z59.71. We also have a new code, the Z59.72. So we have insufficient welfare support, as well as inadequate welfare support. So items for those, looking at especially when you have cases where patients are experiencing poverty, just these are potential codes that you might be incorporating into your practice. Did have some revisions for BMI. We revised to Z68.54. The new codes for body mass index are here as well. So instead of just using the Z68.5, we do have more specificity for that, going off of the BMI of 120% of the 95th percentile for age to less than 140, and then greater or equal to 140% of 95th percentile for that Z68.56. So again, adding in different ranges for your BMIs to go. And correct me if I'm wrong, Jan, I believe 120 was previously the top for these. So this is something to please take note of when you're seeing your patients and pay attention to that BMI, because before that 120 was your default if it was higher than that. So you now have that gap between 120 and 140, and then 140 is kind of your new ceiling for those. And yeah, the next one is just top 10 ICDs. This is PCC usage over the last 365 days. So this is more just informational, seeing what we have. Again, our Z00.129s, your normal routine visits without abnormal findings is our top. And then right behind that is our immunizations. Those are, I'm trying to think, is that 4? Yes, 4 million. Yeah, over 4.5 million. 4.79 million instances of that being billed out with the software. So across all of our clients, that is a rather large amount of well visits that you guys are doing for your patients. And I think that's it. Do you have any additions that you would like to add on to that?
Yes, thank you for satisfying my curiosity. That last slide was just for me.
Yeah, Jan just said thanks.
Yeah, I know I have to use the microphone. I don't like it any more than any of y'all do. That last slide is really just my curiosity. I entertain myself with this data. I get geeky when I know that we're coming up with some new codes, and I just look at over time at the usage of the entire PCC provider population for the fun of it, and that was just so thank you for bearing with me.
Can we bear with me for a hot second? And I'm just so curious. The 10th most used code is RO 5.9 null. What does that mean?
That should.
It used to be cough unspecified, and then it got a new code.
It got a new code. So yeah, this is me being like finger wagging. That RO59 should not even be there. The fact that it was used that many times when it is not a valid code says that folks are getting in habits and just sticking with what's on their forms or what's linked to their SNOMEDs. So this is my request to you to go back and take a look at the codes that are linked to your top 10, so we can help you run reports to discover what the most used ICDs are for your encounters, and make sure that they're mapped to valid and helpful payable codes.
Well, gee, I'm glad I asked. Because they're around a third of a million. 300, and actually almost 0.4 million. Sweet. Kristen.
I'd like to take a short intermission to thank Brenna from Topeka for actually taking me seriously for the last drop-in and bringing us chocolate. She apparently brought it through very warm airports and somehow kept it from melting. So thank you, Brenna.
Yes. Thank you, Brenna. Kelsey, did we have anything on the chat?
So let me, sorry, I have to, okay. So Susie from the chat says that we just received our first shipment of Flucelvax and the NDC is not applicable in the EHR. We have been in touch with PCC and the manufacturer is anyone else having this issue. So I kind of want to wait to see if anybody in this room live is having the issue, because people in the chat have been able to look at it for a bit.
You said they got a new shipment of vaccines where the NDC wasn't valid?
Yeah, so there is some good news, which is our awesome support team back home did answer Susie, but I was just wondering if anybody here had the same issue as her. So I'm going to read what they wrote, because it's much easier. So apparently the CDC NDC crosswalk table doesn't have the NDC listed for Flucelvax, so there is a page where you get to see all the NDC, and it just says it's not available at the moment. It looks like it's going to use CVX 153, as some have been told by their reps. But even so, without the NDC in the system, it cannot be added. Per our CDX team, you will have to wait for the CDC before it can be added, but you can send the CVX and MVX, and after the CC update, you can run a report for all administered vaccines and adjust their lot using that info. So if you do run into this issue in the future, just keep that in mind. Oh, and Susie responded and said, thank you. Kelsey, you're welcome, Susie. We are waiting to submit claims and checking every day to see if it comes up. No need to ask the question. Oh, I'm sorry, I asked the question, Susie. I didn't see that part. It's too late.
That's
I asked
okay,
it.
Susie. Hey, Susie. Susie's one of our drop-in regulars. So, sweet. Do we have any other questions in the room? We're supposed to wrap up in about 10 minutes here. So if there are no other questions, then I might hand it over to Michael if he wants to do a little bit of show and tell. Sweet. Oh yes. While Michael gets that set up. No, that's perfect. No, that's perfect. We can ask questions while Michael gets that set up. No, please, here.
Did anyone ask about CARC code reporting? Okay. So when you guys, when we get the CARC report, and I guess in PM, it shows by account numbers. And is there any way to efficiently identify which patient it actually is as opposed to the account on a CARC report?
I'd have to take a look to make sure. So those CARC reports specifically, the ones that are in there, were made as like source reports. So the data in them is very basic. So usually when you customize those reports, you can see if there are additional filters such as show me the patient that has a date of service for things like that. So I'd have to look in and see if that is one of the available line items
Fields,
you
right?
can look towards.
I think Lee tried to look when we were looking in the CART report to filter, or at least just filter out, add and edit.
Yeah.
I guess there was not an option for like.
Yeah, so
PCC.
there's two different things. So like when you're customizing a report, you can decide what the columns are going to be. And then when you're filtering a report, you could say like, oh, I only want to look at for like CARC 45. So filtering and deciding on the columns are slightly different, but we can definitely take a look and see if it has it. My assumption would be that it wouldn't tie to, or no, it might tie to a patient because a line item charge has a patient on it. So it seems like it could be possible. I just have to take a look.
All right, take it away, Michael.
I'm okay. Hi, I'm Michael Stein, and I am the software designer for our folks here to do all this billing stuff. And today I have the privilege to show you a new piece of software that is going to be in the next release. Oh, it's funny. But that's our original logo you're looking at there. Very retro.
That's a 40-year-old logo.
It's gone now. Okay, so the program is bills, and so what we're doing is with some of the software we reimagine things and we build new workflow. This is not that exactly. This is what we call a port. So we're taking the bills program that's currently in practice management, and we're putting that functionality in the EHR, and we're doing it in just in a quick way, but hopefully it'll give you a nice user experience, and you won't have to go to the practice management to do that. So this is a working piece of software, but I'm not going to do a live demo because all sorts of things can happen in a live demo, and especially with bills, you have to prepare them and you have to wait, and we don't want to do that. So I'll just sort of simulate the live demo. So here we are in the EHR. We can do a drop down, and we'll see, look, there's a bills program right next to the claims program. That's going to work. There'll be permissions around that. I'm not going to show that off, but you'll let anyone access that you want. So in here, we have the bills program, and we see tabs on the top. You have electronic bills, paper bills, log. You can configure e-bill messages and paper bill messages. And so you can see that all in one. In the old practice management system, you have electronic bills as one program, and you have paper bills as another program. Technically, they're the same program, but you run them in different ways, and you get either paper bills or electronic bills. But here, you have a choice here. You can go in here, you can just choose which you want. A lot of folks do electronic bills, but not everybody. So we've streamlined the interface a bit. We've pulled out some of the features that were sort of designed for paper bills from 40 years ago, and we just pretty much pick your categories. And there's a select all button, there's a select all, or you can then deselect something. So you can select the categories you want, and you say prepare. You click on prepare, and it says preparing, and you get those little dots that move. It's really nice to watch. Okay, and then when it's done, it tells you that it's prepared, and it shows you how many of each category is ready to go. And on the bottom, you have some buttons. One, start over, work with accounts, close, submit. So if you click on start over, it just puts you right back to the main part, and it basically throws that all away because, oh, I didn't mean to pick the categories I picked. I want to do it again. So now let's just pick them all. Let's pull that one back again. We're preparing. They're prepared to submit. And now you'll see other buttons here. One is work with accounts. So this is also like that program called PurseView in Partner. And this is like the built-in PurseView that works on your prepared bills. And so it's an interactive or somewhat interactive program here. So it gives you basically a work list of all the accounts that you've prepared the bills for, and you can manually sort these columns in any way you want. So you have, if you want to look at the highest amount of overdue in any category, you can go just click on that category header, and it will resort it. And then there are buttons on the bottom, so you can select an account. If you want to look into something or adjust something, there are what we call hooks to different places. So you can hit the payments button, and it will bring you into the payments tool. And then from the payments tool, it brings you to the payment history, and you can see all their payments. You can see a little aging on top. You can also jump over to the posting side, and then from there you can get to account demographics, you can assign flags, you can go to account notes, you can do all that. So if you have to do any of those demographic functions, you can do that. Back in the log, you can also go to correct mistakes. Correct mistakes is actually going to open up a little window that's like the practice, that brings you actually into the practice management, but just into that OOPS program, correct mistakes. And it opens up the window, and it brings you right into correct mistakes for that account. So you don't have to go like digging around back, and it just pops you in there. So if you want to do something in there, you can do that. Or if you just like to look at the history there, you can do that. And then there's preview bill. So if you want to see what does that bill look like before it goes out, you can just hit preview bill. And it shows you in a beautiful monospace font what the bill looks like. And you can scroll and you can find things, you can do search for it, you can just, whatever, enjoy it. And then you click back, and it brings you back to the list. And that is all the fun that's in this work list here. So I'm going to click back, and it brings me back to my prepared bills list. So I can go, okay, I've worked my accounts. I'm now going to submit e-bills. And then you get a little confirmation message saying, sure, you want to? And then you click submit e-bills again. And then it says, hey, I've submitted these bills. And it should echo what you saw on the other screen before. Just a little bit of feedback. And then you dismiss that, and it goes right back to, like, I can do it again. But if you have cycle billing, it's not going to, if you've submitted those bills, they're not going to just print out again because it's going to go, oh, I've just sent out those bills. It'll update the billing cycle. Paper bills is going to work the same way. So I don't need to, I don't think, repeat everything. I can just print the 120-day bills there, prepare. And then I'm going to get the 120-day bills. They're prepared. Now, this time it'll say print paper bills. Printing, da-da-da-da-da-da. They were submitted. Actually, that's a bug there. That's going to say printed. That's already been fixed. And then it's done. Actually, that was the wrong slide there. So then, if you go to the log, you can see all of your submissions, paper or electronic. You'll be able to see who did it, when, and what categories you picked. One of the things I'd like it to do is show whether it was electronic or paper, and it doesn't do that yet. It didn't do that before, and it doesn't do it yet because it's a straight port, but that's something we're going to probably do at some point. If you go into a log, you select a log, it'll show you pretty much, if you look in the top right, it says accounts billed and accounts not billed. So it shows you by default the accounts billed, and these are all the people that were billed. And if you want to, you can view a bill, or you can switch it over to accounts not billed. So basically, you have a record of all the bills. You can always look back at exactly what was on that bill that was sent. You can go to accounts not billed. And this is basically everybody else who didn't get a bill. And it's kind of a weird report, but it's basically showing you, if you wanted to know, why didn't a bill go out for that person? You can always go into here, look up, use a search, find that person, and see, hey, it was because they had no balance that day, or they were already billed out within the cycle, so they were billed last week, so they didn't get another bill. The next tab is the e-billing messages. So this is where you would go to configure. You can have custom messages for each aging category for the bills. And so there's a default message, which if you don't have a message, it'll use that. And then there's all your messages that you have. And so the dimensions of these should match, look very much like what goes on your bills. And the paper billing messages might have a different dimension because one is electronic bills, they're just different bills, so they have different shapes to them. And that's the bills program. A question. So, it's the same thing you're used to, but,
I have a question. Are we going to be able to print out like a list of the bills that we're sending out?
The bills, the list,
Like a list. Like
So,
I
the
do this-
log.
Yes, a log.
Oh, is there a print? I don't think there's a print button, is there? Maybe not yet, but there can be a print button. I think it's funny, I remember talking about this. My feeling is anytime that you have a list, you want to be able to print it.
So when you say print a list of the people, do you mean you want to print a list before you print the bills, or print a list after you've already printed the bills?
Before I print the bills.
Okay. So you want to look at who's going to be getting a bill before you confirm and submit?
Yeah.
Okay.
Yeah, I'm totally writing this. Oh, I'm writing this down. So I have questions for you, Hortensia. What do you do with this list, that you print out?
Before printing it out, in the middle of the month, I just like to go through it, review it, and if they're like super huge balances, to see what I can work out with the patients and stuff like that.
Okay. Is there any questions that Kristen had? That was not that one. No, same thing. Okay.
And also, for the time being as a workaround, you could always prepare a list and then sort it and just not submit the bills. You could use it as an active work list and go through without submitting them. You could just prepare them, right, and then close it and go back. You wouldn't be able to print it, but it would still be an interactive work list that you could work through based on the balances. Yeah. Oh yeah, we have one more question. And I will say that we are over time, so if anybody needs to leave, then that is totally okay. But
The only thing left is Chip. I was just going to say, I used the list for my mail merging, so it just would be easy for me to put that into my spreadsheet and see all my addresses at the time that I send the bills out.
And would that also be ahead of time, or would that be better for
The
after?
log is fine for me. I understand the ahead of time as well for just checking to make sure that I have the balances and tackle the ones I want to hit first.
Okay.
But afterwards is fine for me too, for my
Yeah,
log.
you're saying it's for your mail service. That seems like that would also be okay if it was a post producing the bills, then you've got that so you can send to the mail. Okay.
Yes, thank you.
Thank you.
thank you.
And I am so sorry. Online, there's the question of when's the new bills program rolling out? Oh, yeah.
That is a great question, Kelsey.
That is a fantastic question. So we are hoping to have this ready for our next release, which is 10.1, which comes out in October. So just want to let you know that is our projected timeline.
Are they going to be going out to their emails or or how?
To my knowledge, this is, I don't know why I am making that so loud. I'm going to sit next to Kelsey because apparently this isn't a problem. The understanding is this is going to be basically a version of that in the EHR. So as it's currently functioning, this is just going to be what you're currently using in practice management. It's just going to be accessible and usable in the EHR, and maybe with some little niceties added, but no, it won't be anything like sending it out to emails.
And we are going to wrap it up today. Oh, well, that's going to be tiny, isn't it? Well, how did I just do, okay, well. No. All right, well, we'll click this for now. Michael might be able to do it. But so just so everybody knows, our next two drop-ins. One is on August 20th, 2024, and the other one is going to be on September 18th. And as you all know, all of the recordings, the slides, everything are going to be online and available for you guys from this billing drop-in and past billing drop-ins and future billing drop-ins. Thank you guys so much for coming, and we're super happy to see your faces in real life. And again, like I said, for anybody in the room or anybody at home, the billing drop-in doesn't really end right now. You can always reach out to us. You can always reach out to each other. The support is kind of nonstop, so just let us know, and we're happy to help. Thank you guys for coming.